So, first one is bruisability. Bruisability has a discriminant factor of 10.3 followed by proximal myopathy, third comes plethora, fourth comes stria. So these four features are going to help us discriminate between what features are going to be more specific towards Cushing's. So whom do we screen basically? We screen the following. One is, not every person that is going to come to us with obesity or just central obesity that we are going to screen. We are going to screen the following. So if a patient comes to us with central obesity, along with that, if there are features of protein catabolism. What are the protein catabolism features that are common? We have seen that myopathy, proximal myopathy, then we have seen facial plethora, bruise, facial plethora, stria, bruise, and proximal myopathy. So these are the patients who having the discriminant features that we are going to screen. If a patient is having short stature with obesity, or a child with short stature or decreased growth velocity with obesity. So usually what happens in obesity is that the height will also increase and the weight will also increase. But if the weight is going to increase more than the height disproportionately, or there is faltering of growth along with obesity, this is classical of childhood Cushing's. So this patient we should always screen. We should always screen osteoporosis in a young age. We should always go for metabolic syndrome with hirsutism. We should also go for adrenal incidentalomas. So in case of adrenal incidentalomas, we have to always rule out certain disorders such as Cushing syndrome, such as primary hyperaldosteronism, such as pheochromocytoma. So these functional adenomas, whether the incidentaloma is functional or not. What is incidentaloma? Adrenal incidentaloma is a subcentimetric adenoma, sometimes even more than 1 centimeter. But we are not looking for adrenal pathology, and we catch this in the imaging. So this is known as adrenal incidentaloma. So this we have to be very careful of. Then after this is, what are the clinical signs that are more common in endogenous as compared to those in exogenous. So exogenous, the patients will have going to have more of cataract, which is going to be bilateral, posterior subcapsular. Features of protein catabolism are going to be more because of more potent steroids being used. Then there is going to be glaucoma, pancreatitis, panniculitis. Then there is going to be something that is known as your spinal epidural lipomatosis. Then there is going to be something very important which we have seen in this COVID era. Lot of AVN of the femoral head is going to be there. Why that is going to be there, we are going to see. So why AVN occurs here? So it is a end artery, end arterial supply is there. There is always fat embolism risk is there. Then there is marrow adipogenesis is there. Marrow adipogenesis is there. Then there are going to be microfractures. Microfractures are going to be there, and they are going to cause problem in the blood supply. Yes, so this is going to cause AVN. Then this BIH, or what we call as idiopathic intracranial hypertension, is much more common in steroids when taken exogenously, while the endogenous is much more common. Three factors, the 3H, the hypertension 75% as opposed to 20%, 25%. Then it is hirsutism, hyperpigmentation. So hyperpigmentation. These things are much more common in the endogenous part of the disease. Now we come to what is the diagnostic workup? Causes of hypercortisolism other than Cushing syndrome. So we see that there is a clinical feature of hypercortisolism is there. So we can imagine that a lady is coming to us at, say for example, 47 years of age with 110 kg, BMI of more than 35, and what we are seeing that there is a mooning of the face is there. There is proximal myopathy is also there. There is a red hue on the face, and there are multiple features that are very, very consistent with endogenous hypercortisolemia. Diabetes is there. There is uncontrolled hypertension is there. The lady is telling us that there is a lot of headache. Sometimes field cuts are also occurring. Sometimes there is also, she is also saying that there is some kind of falteration of or darkening of the complexion is there. So we see that there are clinical features of hypercortisolism with high discriminant features. We all know how to remember this. Bruisability, proximal myopathy, plethora, stria. They are present, but still we rule out causes of hypercortisolism other than Cushing syndrome, which is intense exercise, stress. This can be either surgery, can be infection, can be trauma, malnutrition, can be anorexia nervosa. So these are the factors which we need to look at when we look for Cushing syndrome, so that these things are ruled out and we can proceed towards understanding what is the cause of the Cushing syndrome. So first question we ask is whether the patient has Cushing syndrome. So we rule these things out. We rule the pseudo Cushing states. Pseudo Cushing states are your obesity, then pregnancy, depression, and alcoholism. So once we rule this out, so we go towards the first test. What is the first test? The first test is serum cortisol at 8 a.m. So the normal, say for example, like in our lab, it is 4.21 to 22 microgram per deciliter. This is the normal value. So what is the thing that we always assess when we look for serum cortisol is whether the disease is exogenous or endogenous. So how do we assess this? If it is exogenous, so steroids are there, they are going to cause reduction in ACTH. This ACTH is then going to further reduce the cortisol. So in exogenous, it is going to be suppressed, while it is going to be high in endogenous hypercortisolism. So what are the other advantages of doing morning 8 a.m. cortisol, other than whether it is exogenous or endogenous? So one is that we have to do it for baseline HD-DST to check whether it is going to be suppressed or not. The second thing is we need to understand whether there is loss of diurnal variation. So what is diurnal variation? Why there is diurnal variation? Why there is diurnal variation? The diurnal variation of this hormone is very important to prevent this hypercortisolemia. So what happens is that between 4 a.m. to 8 a.m. the serum cortisol is at the highest and it is the lowest at 11 p.m. to 12 midnight. And why this happens? This happens to prevent the hypercortisolemia. And loss of diurnal variation is the first defect that will occur in Cushing syndrome. And how do you define this? So loss of diurnal variation is actually defined as following. One is that there is 50% increase in the 4 p.m. cortisol as compared to this 8 a.m. cortisol. So this is loss of diurnal variation. Or 11 p.m. cortisol, which is supposed to be at its lowest, is more than 207 nanomole per liter. So this is the definition, and this is also used to differentiate between glucocorticoid resistance syndrome and Cushing's, because this is preserved. This diurnal variation is actually preserved in two conditions. One is the glucocorticoid resistance syndrome and pregnancy, while it is affected in seizure disorder, or if a patient is on anti-epileptic drugs, or the patient is a shift worker, or the patient is having depression. So this is the use of this 8 am cortisol. After this, say for example, the 8 am cortisol is high. So now we are going to go ahead with the protocol for endogenous Cushing syndrome. So if 8 am cortisol is high, we are going to proceed with the diagnostic protocol for endogenous Cushing syndrome. So for endogenous Cushing syndrome, first we have to go for the screening tests. So the screening tests are as follows. One is the urinary free cortisol, the another is the late night serum salivary cortisol, and the overnight DEXA suppression test. So you might think as to why dexamethasone is used and why not any other steroid is used. So there are many reasons for this. One is it is 17 times more potent than hydrocortisone. Secondly, it crosses the blood-brain barrier very easily without combining with CBG. Third, it does not cross react with intermediates such as DOCA, which is a problem with hydrocortisone. So that is why dexamethasone is preferred. How is this ONDST performed? What is done in UFC and what is done in LNSC? ONDST is going to be performed when 1 milligram of DEXA is given at 11 p.m. at night, and then serum cortisol 8 am is assessed, and if it is suppressed to less than 1.8 microgram per deciliter, it is negative, while if it is not suppressed to 1.8 microgram per deciliter, it is above that, then it is considered positive. So why this should be positive in endogenous hypercortisolemia is that this amount of dexamethasone is not able to suppress the cortisol because the negative feedback is set at a higher point. The sensitivity and the specificity for this is 95% and 80% respectively. Now, when ONDST can be false positive or false negative. So this is very important. When it is false positive, when it is false negative. So it is going to be false positive when there is going to be something which is known as pseudo Cushing's. We saw that there can be biochemical anomalies in pseudo Cushing's. So one is that. The second is that there can be chronic kidney disease. Then there can be something which is known as glucocorticoid resistance syndrome. Then there can be something known as acute stress. Stress will cause increase in the cortisol level, as cortisol is a stress hormone. We all know that. Then there can be microsomal enzyme inducers such as rifampicin, such as phenytoin or phenobarb. There can be something known as pioglitazone. This is new. Pioglitazone can cause this. Carbamazepine can cause this. So these are the drugs that can cause a false positive. Then conditions that are going to have an increase in the cortisol binding globulin levels. So what happens is that 90% of the cortisol is bound to cortisol binding globulin while 10% is free. So conditions that are going to increase this CBG is going to have a false positive impact on this test, such as pregnancy, such as estrogen, that is can be OC pills. So OC pills need to be stopped 6 weeks prior to testing. Then there is tamoxifen, that is a selective estrogen receptor modulator. Then there is something known as mitotane. It is the only drug that is adrenolytic, and this causes increase in the CBG levels. Then there can be something known as inter-individual variation. So these are the 7 causes. There can be either your pseudo-Cushing's, CKD, there can be something known as glucocorticoid syndromes, microsomal enzyme inducers, acute stress, there can be drugs or conditions causing increase in the CBG, such as your estrogens, such as your pregnancy, such as tamoxifen or mitotane, or inter-individual variation. So after this, what causes false negative? False negative is caused when there is cyclical Cushing's. So we saw that in cyclical there can be peaks and troughs. So हमने अगर trough के time पे, if we do it at the trough time when the disease is inactive, at that time if we do, it is going to be false negative. Then if there is anything microsomal enzyme inhibitors such as ritonavir, itraconazole, or there can be cimetidine, fluoxetine. So if these things are going to be there, they can be false negative. And what we need to understand about the screening tests is that among the UFC, LNSC and the ONDST, at least 2 of them should be positive. Alright, so okay. Now what we need to understand is, in case of certain disorders where even the 8 AM cortisol can misfire, that is, there is exogenous Cushing's and they have a increased 8 AM cortisol. It can occur in 2 cases. Number 1, that if the patient is on a hydrocortisone or a steroid dose, or the HPA axis is now in the recovering phase. The reverse of this can also happen, that the patient is actually endogenous and the 8 AM cortisol is now low, This can occur in cyclical Cushing syndrome. This can occur in your GIP induced Cushing syndrome. It can occur if the patient is on ketoconazole therapy. It can also occur if there is bleeding inside the tumor, that is pituitary apoplexy. So here 8 am cortisol can also flounder. Now we come to our screening tests. So UFC will go first. So in case of UFC, what we need to understand? UFC, the basis of this test is that first we have to understand that because the cortisol basically is bound to your CBG. This CBG, it is bound to 90% of your cortisol is bound to CBG and 10% is free. But if there is enormous hypercortisolemia, this CBG gets saturated and the free portion starts to increase. This free portion is actually going to be filtered in the glomerulus and 90% of it will further be reabsorbed. But this reabsorption mechanism also starts to get saturated and the free cortisol levels start increasing in the urine. So what are the things that we need to assess when we go for our urinary free cortisol? So number one, what precautions we need to take? So what are the precautions we need to undertake when we are looking for the UFC, which is the urinary free cortisol? So first is that there should be a 24-hour urinary collection. That is the first prerequisite. There should be adequate water intake. So overhydration should be avoided. Then we have to see that there is avoidance of this excessive water intake. The third thing we need to see is that there should be proper refrigeration. So this is the problem that we are having. Proper refrigeration but no freezing. So it's very difficult in resource limited settings like in our country, at least in the non-central institutes, that we should get a refrigerator which is exclusive for storing this test sample. There should be a simultaneous measurement of urinary creatinine. So this is the precautions that we need to take. What are the other problems that may occur? So adequate urinary collection may not take place. Adequate collection and storage. That is a significant issue. Then, in case of subclinical Cushing's, or adrenal Cushing's, in both cases it can be false negative. That can also happen in case of mild as Cushing syndrome or cyclical Cushing syndrome. And it is not a good test if there is renal insufficiency. Renal insufficiency is here defined as eGFR of less than 60 ml per minute. So here it can be false negative. These are the cases where it can be false negative, be it subclinical, be it adrenal, be it mild, be it cyclical, or it can have a renal insufficiency angle, or it can have a problem with the collection or the storage. So these are the cases in which there can be a false negative. While in case of false positive, polyuria is one cause. Then there are drugs such as fenofibrate and carbamazepine. They can cause false positive. Then there can be synthetic glucocorticoids. These synthetic glucocorticoids can have interference with the immunoassays. That can also occur because of an interaction with DOCA. Drugs that inhibit the 11 beta HSD2. So this is your good old Mulati or carbinoxolone. Or that is a compound in licorice. So this is the thing that we need to be very wary of. The thing with urinary free cortisol is that it has to be repeated 2 times within or in a gap of 24 hours. Why? Because to rule out the cortisol variation, the variation in the cortisol metabolism, and a normal UFC does not rule out cortisolemia, hypercortisolemia. As far as 8 to 15% cases may have normal or negative UFC. And where are the places where UFC is to be used? So one is that this is the free cortisol. So wherever the CBG is getting affected, at that time we have to use this, such as in pregnancy, such as in patients on mitotin therapy, patients on tamoxifen. We have seen that in cyclical Cushing's 2 tests are used. One of them is your UFC, the other is LNSC. Then for post-op follow-up, if we have to assess whether the surgery was a success or a failure, so that is where we need UFC. So it is said to be a measure of integrated measure of cortisol secretion. Integrated measure, that is very important. And what we need to do is at least 2 values we need to do consecutively within 24 hours. And it is done to minimize the effect of the cortisol metabolism, and the values are this. So values are 80 to 120 microgram per deciliter or 220 to 330 nanomole per liter. And this has to be above the upper limit of normal range. If it is more than 4 times the upper limit of normal range, it is Cushing's until proven otherwise. And if it is more than 5 times, then this is indicative of extremely high hypercortisolemia, and we may need to give the patient cotrimoxazole prophylaxis so as to protect the patient from this immunocompromised state. Now coming on to LNSC. So late night salivary cortisol. So late night salivary cortisol, we have to have certain precautions. The patient should not smoke for at least 24 hours prior to the test. Patient should not brush his teeth or drink water 1 hour prior to the test, and the patient should not eat no food 2 hours prior to the test. 2 hours. And there should be an oral survey or oral examination where we need to assess that there is no ulcer or bleeding which may give rise to false readings, and no tobacco, obviously. Good oral hygiene is a must. That is what it means. The sample is to be taken either by passive drooling. Passive drooling. Or it has to be taken by salivate. Now, the best assay for this is always LCMS more than your CLIA or ELISA, and a reading of more than 2 nanogram per ml is diagnostic. 2 nanogram per ml is diagnostic of endogenous hypercortisolemia. There is another test we can do, that is the midnight cortisol levels, serum cortisol. So what are the precautions that we need to take? Patient needs to be admitted 24 to 48 hours prior to the test. He has to be pre-cannulated because venipuncture stress can also alter this. It has to be either a sleeping sample or an awake sample. So awake sample is that the patient is awake till the sample is taken. Sample has to be taken between 11 pm to 12 pm, 12 midnight. So it has to be taken either awake. Awake means that the patient has not slept only. He is awake. After the sample is taken, then the patient is going to go to sleep. Or sleeping is or has just awoken 5 to 10 minutes before the sample is taken. So either he is asleep or he has awoken just 5 to 10 minutes prior to sample taking. So this is considered as sleeping. While awake he has not slept only. So this is very important, midnight cortisol. And if it is so, first is when we need to go for this test, we have a loss of circadian rhythm is the first thing that goes. So first is the high index of suspicion, and the ONDST as well as your UFC is negative. So if there is high index of suspicion, high suspicion with ONDST and UFC negative, or low index of suspicion with these two tests positive, or UFC and LNSC both are not available with us, or the patient is on some interfering drugs such as anti-epileptic drugs. So this is the time that we need to go for this test. And a sleeping midnight, so the cutoffs are also according to sleep and midnight, sleep and awake. So a sleeping cortisol of less than 1.8 microgram per deciliter or an awake cortisol of less than 7.5 microgram per deciliter practically rules out Cushing's. So this is the comparison of these tests. I'll just do is that I'll just give you the idea of what these tests basically are doing and what they are used for. So UFC and LNSC, they both are used for the free form. And there are various types of precautions that need to be taken. While ONDST and LDDST, and among this UFC is basically a measure of or integrated measure of cortisol. Alright, and in both cases we have to check twice to check for the cortisol metabolism variation. Now in case of O and DST, we saw that the sensitivity was 95%, specificity is 80%, and LDDST, the sensitivity and specificity is much higher. The sensitivity is 98 to 100, while the specificity is also high at 97 to 100. So when we go for ONDST is when we have specific features of Cushing's. So we go for a test with even low specificity because the clinical features are sufficing for it. While in LDDST, when there is low index of suspicion or there are no specific features and we need to go for this, then we do LDDST. How is LDDST done? 0.5 mg of dexamethasone is given every 6 hourly for 48 hours, and then after the last dose the serum cortisol is checked, and if it is more than 1.8 microgram per deciliter, it is non-suppressed and it favors Cushing syndrome. While if it is suppressed, then it is a negative test. So this is something that we need to understand. We come to this feature of tests such as ONDST, LDDST, UFC, LNSC and midnight serum cortisol levels. So less than 1.8 microgram per deciliter, negative test, so more than 1.8 is positive. Here also more than 1.8 microgram is positive per deciliter. UFC more than the 330 nanomole per liter or more than this 120 microgram per deciliter. So that is positive. LNSC again more than 2 nanogram per ml. Then your midnight serum cortisol more than 1.8 or more than 7.5 microgram per deciliter, sleeping or awake. And now what are the sensitivity specificities? So ONDST 95 and 80%, 98 to 100% in case of LDDST sensitivity, and the specificity is also 97 to 100%. The UFC on the other hand, the sensitivity is 95 to 100%, but specificity cannot be determined. And in LNSC as well as the sleeping midnight cortisol, here the sensitivity of both is 100%. LNSC as well as the midnight serum cortisol. So here the sensitivity remains to be 100%. This is absolutely wonderful. And LNSC on the other hand has a specificity very high of 96%. So this is absolutely wonderful. So now what we have seen, the patient is having two tests, positive screening test. So now we go for confirmation, and we go for testing either of these tests such as the UFC, LNSC and LDDST. These kind of tests we have performed twice and they have come out to be positive. So now we test for ACTH. We test for ACTH because of two things: whether the Cushing's is ACTH-dependent or ACTH-independent, or it is ectopic ACTH secreting Cushing's. ACTH-dependent, the cutoff is actually ACTH more than 20 picogram per ml. This is 8 am. Or if we are going to do 11 pm, then it is going to be more than 22 picogram per ml. If it is ACTH independent, then it is less than 5 picogram per ml. And if it is ectopic, ACTH is more than 90 picogram per ml. Now you will ask that what happens if it is ACTH is between 5 to 22 picogram per ml. So in that case we go for CRH stimulation test. Here what we have is a ovine CRH, and this ovine CRH we have to give 1 microgram per kg, not more than 100 microgram. And why we give ovine, we don't give this human, is because this is more specific, it is more potent. So we give this and then again we check. We check the ACTH. If ACTH is now less than 20 picogram per ml, or it is more than 20 picogram per ml. If it is less than 20, we go for an ACTH independent, while this will go for ACTH dependent. So we have assessed according to ACTH. If it is less than 5 picogram per ml, we will go towards ACTH independent. If it is more than 20 picogram per ml, it is ACTH dependent. If it is between 5 to 22 picogram per ml, then we go for CRH stimulation. Here if it is less than 20 picogram per ml ACTH, we go towards ACTH independent. If ACTH is then more than 22 or 20, we go towards ACTH dependent. So this is how things are done. After this, once we have determined that it is ACTH dependent, then we go for MRI pituitary protocol. With dynamic contrast. What we are going to do in this? If the tumor is there, adenoma more than 6 mm, we are going to directly go for IV CRH testing or DST. If they are concordant, what do you mean by concordance? That after IV CRH test, things are going to get increased. DST, we are giving either 8 mg at 11 pm or 2 mg 6 hourly for 48 hours. And again the suppression is happening. That is it is getting suppressed to more than 50%. If that is happening, then what we can see that all these things are concordant. So we directly go for the transphenodal surgery. So now what we are going to do is we are going to make a table for various tests that we have done. So one is ONDST. So if it is positive when it is more than 1.8 microgram per deciliter, and the sensitivity is 95% and the specificity is around 80%. Now we come to LDDST. LDDST, again, if we are going to give 0.5 milligram of dexa for 48 hours, and we are going to test the serum cortisol after the last dose. So the cutoff is again more than 1.8 microgram per deciliter, with the sensitivity being as high as 98 to 100%, while the specificity also high at 97 to 100%. In case of UFC, the cutoff is more than the upper limit of normal of the SAA, and the sensitivity is 95 to 100%, while the specificity of this assay remains unknown. For late night salivary cortisol, the cutoff is more than 2 nanogram per ml, and the sensitivity is a perfect 100 with a specificity being at 96%. So it's a near perfect test. And the midnight salivary cortisol or the midnight serum cortisol, pardon me, it is the midnight serum cortisol. If it is more than 1.8 microgram per deciliter, the sensitivity again is a perfect 100 and the specificity is very low at 20%. While the awake midnight cortisol, the cutoff is more than 7.5 microgram per deciliter and the sensitivity is 94%, while the specificity is highest at 100%. So this is in brief what the tests we have done. So basically what we have here seen is we have tested the 8 am cortisol. Once that 8 am cortisol is either suppressed or increased. If it is suppressed, then this is exogenous. If it is increased, it is endogenous. We then go for the screening tests. They can be either urinary free cortisol or late night salivary cortisol or a midnight serum cortisol, which is either sleeping or awake, or we can have LD DST. And any two of the following need to be positive. After this, what we need to test is whether the cortisolemia is ACTH dependent or independent. So how do we test for this? So ACTH is as well as PTH in endocrinology are extremely temperature sensitive hormonal assays. So they need to be collected very carefully and stored at -20 degrees Celsius and processed as soon as possible. And if the ACTH value is going to be more than 20 picogram per ml, then this is ACTH dependent. While if it is less than 5 picogram per ml, this is, mind you, ACTH at 8 am. If 11 pm is done, then the cutoff is more than 22 picogram per ml. If the ACTH on the other hand is less than 5 picogram per ml, the cause is ACTH independent. And another thing, if the ACTH levels are more than 90 picogram per ml, then it points towards ectopic ACTH producing Cushing syndrome. So then we will go for whether it is, what is the etiology. ACTH will tell us this. Say for example, our patient comes out to be 40 picogram per ml. So if the ACTH is 40 picogram per ml, this shows that it is ACTH dependent. And this is less than 90. So it seems to be ACTH dependent utopic cause. That is, the most common cause here would be a pituitary adenoma. Alright. So how do we assess? If this is the case, then if ACTH is less than 90 but more than 20, that is 20 to 90 picogram per ml. So we directly go for MRI SELA. But if it is 92, say for example, picogram per ml ACTH, then we have to see whether it is ectopic. So what are the things that we need to go for in order to see whether the patient is having ectopic versus pituitary Cushing's? One of the tests between ACTH dependent pituitary and ectopic cause. So first thing was that ACTH is going to be between 20 to 90 picogram per ml or more than 20 picogram per ml. Here it is going to be very high, 90 picogram per ml. So we are going to go for a high dose DEXA suppression test. So what this high dose DEXA suppression test actually does, because of hypercortisolemia that the adenoma is producing because of the ACTH, the cutoff for the negative feedback from cortisol is actually made at a higher level. So the set point is higher than normal. So if we are going to give a low dose DEXA suppression, it is going to maybe get unsuppressed. It is obviously going to get unsuppressed. Why? Because a low dose steroid or DEXA is not going to have a negative feedback in order to suppress the cortisol production to less than 1.8 microgram per deciliter. But in case of Cushing's disease, since this set point is higher at a high dose of DEXA suppression test, which is 2 milligram every 6 hourly for 48 hours, we again go for this suppression or not by testing serum cortisol. And we do a basal serum cortisol before starting the test. And if the final cortisol levels after the 2 milligram of DEXA for 48 hours every 6 hourly After that, the cortisol level is still more than 50% of the basal value. That means that test is unsuppressed. While if the cortisol value is less than 50% of the basal cortisol value, that means this HD-DST, it is suppressed. So if it is suppressed, then it confirms that the cause is a pituitary cause. While if this cortisol is not suppressed, that is, it is more than 50% of the basal value, then it points towards ectopic Cushing syndrome. So we can see here that the first thing is going to be that in case of ectopic versus pituitary cause, HD-DST remains unsuppressed. While here HD-DST, the cortisol gets suppressed. Other thing, we have already seen that ACTH is going to be more than 90 picogram per ml. Here it is going to be more than 20 picogram per ml. The other thing that we can see is we can see a response, ACTH response to CRH. We have seen this. So CRH is corticotropin releasing hormone. It is given in the dose of 1 microgram per kg to a maximum of 100 microgram per day. It is of ovine origin because this is more potent and we check for ACTH levels after this and the cortisol levels. So normally if it is a pituitary cause and we give CRH, CRH is usually physiologically coming from hypothalamus, but here we are giving it from outside. So what it should do is that it should stimulate the production of ACTH from the pituitary and subsequently increase the production of cortisol from the adrenals. So if this happens, that is ACTH is more than 100% increase from the basal value. Basal value is the one that we have done before the test, or the cortisol level, serum cortisol, is increased by more than 50% of the basal value. We say that this is a positive response to CRH. So this will again point towards a pituitary cause. While in ectopic, the CRH, if given, will not increase ACTH or cortisol levels to the same extent. The pituitary causes will subsequently have also one more thing. If we go for IPSS, inferior petrosal sinus sampling, if we go for this, then what we are supposed to get? So we are supposed to get a gradient between what the inferior petrosal sinus does is it drains the ipsilateral part of the pituitary. So functionally the pituitary may be divided into left and right parts, and 60% of the time it is also symmetrical. So one half of the pituitary, the blood is drained into the ipsilateral petrosal sinus, that is the left half of the pituitary drains in the left petrosal sinus, in left inferior petrosal sinus, while the right half drains into the right half of the petrosal sinus. So if there is a pituitary cause, the gradient, that is the sample from the petrosal sinuses to the peripheral sample, should have a gradient of around 3, more than equal to 3, if it is CRH stimulated sample. While if it is normally not CRH stimulated, just like that we are taking, so it should be more than equal to 2. That will point towards the pituitary cause of the Cushing's. While if it is not having a gradient, that is less than 1.4 gradient is there, then we will say that it is not a pituitary cause, it is either ectopic or it can be adrenal. But if it is adrenal, we will not go for IPSS in the first place. So basically what they are trying to say is that ACTH may be high in case of ectopic as well as pituitary causes, but if the gradient is not there, that is the pituitary to peripheral gradient of more than 3, if CRH stimulated, or non-stimulated more than 2, if this is not there, then it points towards the ectopic cause of Cushing's. While if this gradient is there, what it helps us is in lateralizing the area where the adenoma is there. This is particularly helpful if the adenoma is less than 6 mm and is not visual or is not visualized on MRI. We will discuss this further. So there are 3-4 pointers that point towards pituitary versus ectopic Cushing's. One is a ACTH value of 8 am more than 20 picogram per ml, or 11 pm or more than 22 picogram per ml. Then we have a suppressible high dose DEXA suppression test. We have ACTH response to CRH, and we have a central to peripheral ACTH ratio of either more than 3:1 in case of stimulated, or unstimulated more than 2:1. So this will point towards the pituitary cause. While in case of ACTH, here ACTH is going to be more than 90 picogram per ml. It is going to be unsuppressible HD-DST. There is going to be no ACTH response to CRH, and obviously no central to peripheral ACTH gradient. This will point towards ectopic. So this finishes our second part of the diagnostic workup. The first part was whether it is exogenous or endogenous, whether now then we thought that this is okay, this is high, so it is endogenous. After endogenous hypercortisolemia, we have to see whether it is the screening tests are coming positive. So 2 out of the 3 or 2 out of the 4 need to be positive. After that, we see as to whether this cause is ACTH dependent or ACTH independent, which we saw by doing the ACTH levels. And this ACTH levels, if they are more than 20, then we have to assess whether it is pituitary or it is ectopic. That also we have seen via our high dose DEXA suppression test, the ACTH response to CRH and the central to peripheral ACTH ratio. The one thing that we need to be very careful about is that ACTH sample needs to be repeated at least 2 times, and then you make a final call, because there can be a lot of problems with regards to its processing and the cold chain maintenance. So that is something we need to be very wary of in case of ACTH and also in case of parathormone. So this is something we should be keeping in mind when we are evaluating for the cause of endogenous hypercortisolemia. Next, we will discuss what is the imaging technique and inferior petrosal sinus sampling and how to do it and what are the caveats regarding it. Following that, we will go towards the medical management if and when it is required, and then we'll wrap it up with just a few takeaways and the prognostic indicators of whether the disease has remitted or whether it has been cured, whether it is persisting or whether it is recurring. Thank you.